Great. I'd like to give us a couple of minutes for discussions. Sam, you were answering some questions on the Checkmate 649 assays. Do you want to comment on that?
Sure. I think it's a really big topic, probably, require a whole nother discussion, but someone had asked about, in your case, would you retest with 28.8 since that was the antibody used in 649? And my, at least at our institution and probably your practice, I imagine, is somewhat similar. We don't have multiple antibodies that we use routinely, and so we're committed to one and use that. There are differences, as we know. There's been some comparative papers and a recent paper from pathology looking at the inter-observer variability between PD-L1 reporting with CPS, which is not so reassuring. Concordance is high with tumor cell scoring, but in the immune cells, it's not very good. You could basically ask your pathologist to make a 3 of 5 if you wanted to, is sort of the take home. But no, we do not routinely test with another antibody, but we do try to discuss cases and make sure that the pathologist had a good slide to review. There's good tumor cell content on the slide. And then we also try to test the most recent sample that we have, especially if it's from the outside, and try to test as many samples as are available, because we just want to make sure we're giving the patient the best chance and having the most data points to see if it makes sense to think about adding. So short answer is no, we don't routinely test with multiple antibodies.
Totally agree. So we tend to test with 28.8 now because I thought maybe the pickup would be a little bit higher. But I'll be honest, there were data presented at ASCO last year showing that 28.8 was picking up many more patients than 22.3C. So I sent 50 patients back to be retested, and I did only find one that crossed the barrier. So I wasn't convinced that was what we were seeing in real life. But I think you made a really important point there, is that we should test the most contemporaneous biopsy, because it's really, we see these are dynamic. PD-L1 is dynamic, and it can also decay over time, right? And so if you're looking at a resection specimen from 2 years ago, it just might not be the most accurate assessment of the patient's PD-L1 status. I see there's some questions there in the chat about, are we doing Claudin routinely? No, we're not doing Claudin routinely yet. I think that there's a lot of discussion around it. We're waiting until we have an approval, and then we'll set up the testing.
Great discussion. I think it's important to think about in advance on the treatment strategy and allow for as many options, and to just change with both standard and experimental options. And that's why having trastuzumab deruxtecan and other second-line therapies would be great. And we talked a little bit in the chat about biomarker testing. I think you have to go into the battle with updated maps. So test routinely and retest if anything is of question, particularly HER2 in second-line setting. So that's one way to know what options to offer the patient, and realize that there's a rate of attrition between second and third line, even in Asia, where patients are really robust. Not everyone gets a third line therapy, and certainly in our clinics, patients deteriorate pretty quickly. I think specialized nursing care, symptom management is the way to see your patients through as many options as possible. For FLOT, we routinely use growth factor support and delayed emesis regimens. So giving patients Emend and Decadron is important to get them through therapy. I often see them during the week off at the beginning for a little hydration and a pep talk on what to eat and how to eat. So you're able to really get them through more with specialized nursing and MD care.
Totally agree with you, Elena. I mean, the care of upper GI patients is holistic, right? So we're talking about all these wonderful new drugs we're using, but it really needs to be wraparound, and it's about the whole patient. And our patients are seen by, we have a wonderful nutrition team, and, trying to get on top of weight loss and maintain strength is really important. There is a phase 3 randomized trial published in JCO last year that showed that early palliative care for patients, and palliative care means looking after the patient in terms of symptom control and nutrition, improves survival for upper GI patients. So not to forget that. That's a really important point.
Well, feel free to unmute and ask us questions live. It would be great. It's such a great turnout. I appreciate your time. in the afternoon. I know everyone's excited to learn about the updates. I think the next approval in the space will be zolbetuximab in combination with systemic therapy. It's certainly important to keep an eye, as I mentioned, on perioperative data. Thanks for that kind feedback. It's really always nice to see so many people interested in this relatively rare disease. So I think there's an MSI patient question. If the patient with MSI tumor received first-line chemo without IO and progressed after 1 year of therapy, would you recommend chemo plus immunotherapy or just pembro? In this patient, I would just use immunotherapy alone. Pembrolizumab is still FDA approved in later lines of therapy. I think often the other question comes up. We start, for example, with FOLFOX nivolumab in first line, and then the MSI testing comes back, and then the patient has MSI. What do you do with systemic therapy? I often keep it on, especially if the patient is tolerating it well, until the first scan. And if there's a great result, I de-escalate the oxaliplatin. Using immunotherapy alone in first line setting is probably enough, but may not be enough in all patients. If you remember the colon cancer first line data, 177, there's a 30% of patients where the curves flip at the beginning. So that's why sometimes having that chemo as a backup in our disease, may be a good option. Published in New England Journal of Medicine earlier, just yesterday, there was an endometrial data set also for first line or for advanced endometrial patients, MSI and MSS, for benefit with chemotherapy or with immunotherapy.
Yeah, I agree. I think that Yelena, because I know that we have the option in the UK to use IO as monotherapy in first line, but there would be patients who I think that are more likely to, are less likely to benefit. Maybe if you saw patients who have a very heavy metastatic burden with ascites or, distant metastases, and not just the chunky MSI tumors you see that tend to have lymph node mets. Certainly that patient, I would be concerned I might want to use chemo as well as immune checkpoint inhibitors.
Sam, do you want to take the NGS question?
Sure. I will take the MSI and the NGS. So yeah, and not all MSI is created equal. I completely agree. I mean, biologically, it's not always an early event, so it can be subclonal, and we see heterogeneous MSI testing by protein not uncommonly if you look at more regions. So I agree. Certainly in people with higher burden, we think about chemo too. When would you recommend NGS testing is a great question. So as Lizzie suggested, when it's available, it is a tool. It is a tool that we primarily use to give context to our standard biomarkers. So as Yelena mentioned, HER2 commonly co-occurs with other things, cyclin E1 amplification, MAP kinase alterations, and we may not use that yet clinically, but it does give us a little bit of worry about, is this patient going to be having a shorter duration of benefit, for example. I'd say the primary use in our setting, and probably the same for others in academic institutions, is as a tool to explore maximal options. So we do it at the get-go in advanced patients to explore other targets like EGFR and MET, and we'll pick up FGFR2 amplifications, sometimes rare biologic subsets that may target patients towards a trial. And then, of course, for research to participate in the larger community of just building these big data sets so we can tease apart groups that may benefit less or more. Certainly, you'll pick up MSI high and TMB. So we use it in the front line at diagnosis. If patients are treated with a targeted therapy, we'll definitely repeat it at the time of progression, either with blood or tissue or both. In patients that don't have tissue, we use plasma-based assays for ctDNA all the time. So I'd say short answer, we do it at frontline new diagnosis of advanced disease.
Great. Well, we had a great discussion today. I think take-home pearls are that these patients are very much treatable. There's a lot of treatment options for patients with early stage and metastatic disease. The biomarker development is prime time and in the clinic. So when the patients are coming in with just one single H&E slide, that's not sufficient. So feel free to request additional slides or even get endoscopic biopsies, because those are relatively quick to get and they're very much actionable. So typically we start with chemotherapy in first line setting and usually use immunotherapy in combination with that. And then you can streamline the duration and the goal of therapy based on the response. You heard great data and reinforcement of that radiation is sort of falling by the wayside because this disease is systemic in nature. People die of stage 4 disease, not of local recurrence. So the wave of the future is to improve systemic treatment options, not just localized therapy. And in the hands of a great surgeon, experienced surgeon, radiation is usually not needed to get an R0 resection, but there are individual cases that you have to discuss with your disease management team. So routinely test for HER2, PD-L1, MSI. NGS is ordered, but perhaps don't wait to start therapy based on NGS. It kind of gives you a better roadmap for the tumor type and the tumor biology. Watch out for claudin inhibitors. They're coming to clinic, and FGFR2b inhibitors as well. Again, it's a pleasure to have you join our seminar. We're all available for a discussion in the future. You can tune in to ASCO for updates and ACR of updates. There'll be some interesting data presented as well. Thank you.